Hi, everyone. Welcome back to part 2 of ethics. And we'll continue on here with decision-making capacity, assessing a patient's capacity for decision-making. So how does an advanced practice know when a patient is not able to make an informed decision? In some cases, the answer to the question is pretty easy. It could be obvious. For example, we know a patient who's a comatose patient wouldn't have the ability to make a decision. A neonate or a child, or maybe an elderly patient with advanced dementia cannot process information, cannot communicate their wishes directly to a provider. So for such patients like these, an alternate decision maker is necessary. So this alternate person acts as a proxy, either to convey what the person's wishes would probably have been, maybe because of knowing that person and knowing their beliefs and values and life goals, or to ensure the patient's probable best interests where no knowledge is possible, maybe a little baby. The issue of decision-making capacity is especially pervasive in mental health settings. So there's certainly some more specifics when we're talking about mental health. So in other cases, determinations of decision-making capacity may be more difficult. So the ones that I just talked about, the elderly person with dementia and the child and somebody who's comatose, certainly might be easy to see that they have the ability to make a decision. Examples of such problems include how and when to determine death, when it's possible to indefinitely prolong somebody's life artificially. And any of you who've worked in the hospital have come across that, as far as putting somebody on a ventilator could prolong their life for many, many days and weeks. And when do we determine death in that situation? What effects are caused by the application of genetic innovations in healthcare? What about health disparities? How could advanced practice nurses help with that? And also important, how do nurses ensure that patients are capable of making their own medical decisions and are not subject to undue interference by interested others, children, spouses, who may actually not be holding the patient's best interests at hand? So just as far as minimal criteria or minimal capacities for decision making, which were concluded by a study of ethical behavior, 3 criteria that would conclude that somebody has minimal capacities for decision making are: number 1, possession of a set of values and goals, that they hold a set of values and goals. Number 2, they have the ability to communicate and to understand information. And number 3, the ability to reason and deliberate about one's choices. That looks better, sorry. So these here are pretty basic criteria to determine that somebody has decision-making capacity. So these criteria are made more stringent in certain circumstances. One where risks are high and the patient seems to be making a choice that is not in line with their own values and goals. Or just when somebody has the possibility that serious harm may exist due to the risk of an action or maybe an inaction, not wanting something or wanting something. Also, we can add here, are they volunteering for this decision? Are they being pressured by internal or external influences? Somebody wanting them to make a particular decision, like a family member, possibly. So those would make kind of like some extra circumstances that could interfere with a person's decision-making capacity. Proxy decision-making is the act of deciding what healthcare actions are permissible for someone who temporarily or permanently has lost decision-making capacities, never had decision-making capacity, somebody who's mentally retarded, or is not yet considered to have sufficient maturity to make healthcare decisions like a child. Now, sometimes when children are involved, the proxy decision maker is usually a parent or a guardian who makes decisions on the child's behalf. Sometimes a child may be developmentally appropriate. Maybe they're a teenager and they may assent or dissent to a course of treatment. They may want something or not want something. However, this child's dissent may be overruled by a parent or guardian if they're under the age of 18, when the risk of not being treated is high. An example of that could be a parent who's not interested in their daughter maybe doing some oral contraception, and the 13-year-old wants that type of treatment. And even though the parent doesn't want it, the parent concedes to something in that manner. So types of proxy decision making. Talked a little bit about these. There's 3 types I'm going to talk about. So when we talk about ethics in literature and practice, there's a hierarchy of 3 levels of proxy decision making used to determine appropriate treatment for those who are or have become incapacitated. Okay. The first level, which is the substituted judgment, I talked a little bit about in the first part. It's based on the principle of autonomy and aims to reproduce as nearly as possible what an incapacitated person's wishes would have been, what your mom's wishes would have been if she were able to make her own decisions. So the person may have previously formulated a written directive, also known as like a living will or an advance directive, or may have appointed a person who could accurately represent those wishes. For example, a mother and telling their child, this is what my wishes are. A wife telling her husband, this is what my wishes are. And then that person can substitute judgment based on the fact that they do know what the person actually, what their wishes would have been. So if these formal type of arrangements don't exist, then the healthcare team may be able to discern what a patient's wishes would likely be by gathering information about the patient from family members or friends. The second level is often called the best interest standard. The best interest standard is invoked when it is not possible to know what the patient would have wanted in the pertaining circumstances. Maybe it was a teenager who was in a bad accident, and this is just not something that's talked about typically with a younger population, and now this person has traumatic brain injury and is unable to make any decisions. In such cases, a surrogate decision is made based on this person's quality of life. Actions are favored if they are likely to provide the highest net benefit in terms of their quality of life. The best interest standard may permit overriding a surrogate decision maker's direction for treatment if that surrogate decision maker proposes a treatment that does not seem capable of benefiting the patient, or maybe could cause more harm than good. So maybe the patient, teenager who is brain dead, a parent wanting them to have a feeding tube and a trach and a vent for the rest of their life. There might be a best interest standard, and that would permit an overriding of a surrogate decision maker. The third level, a reasonable person standard, is used when neither level 1 nor 2 here are applicable. So for example, it's not possible to discern from neonates or anybody who's cognitively disabled what they would want for themselves. So in these cases, a decision is made based on what is reasonable, what a reasonable person would want. And this one right here, this third one, is used more often in research settings, and it can be problematic because it is hard to determine who is reasonable, just based on so many factors. Some legal aspects in regard to proxy decision making. In the United States, what is accepted as legal surrogate decision making differs from state to state. So this necessitates that the advanced practice nurse is familiar with the laws of your state in which you practice. Okay, proxy decision making continued. We'll talk about advanced directives. So advanced directives, so just a little bit about advanced directives. It's obvious that it's generally better for a patient to have considered in advance what sort of care they would like and who might best serve them as a good proxy decision maker on their behalf, although such decisions may be made when patients are already critically ill. And that is not optimal, right? So this decision is being made when the patient is in the ICU and they have just been intubated and they're on dialysis, and the timing is probably not the most optimal time. So adequate time, a low pressure environment, and the assistance of a trusted health provider are probably the best conditions under which to process information. So these would be the best times and circumstances for somebody to make decisions about their advanced directives. So being a good advanced practice nurse means taking the opportunity to raise questions and provide necessary information related to this idea of a proxy decision maker if a patient appears receptive. Just some research I kind of came across was kind of interesting, questioning prospective proxies and those for whom they were to make decisions, found that spouses, so spousal proxies, were more accurate in their substituted judgment than adult children. So the spouse did do a little bit better job with the proxy decision making than the children. And proxies who perceive higher degree of family conflict within their family tended to be less accurate than those with lower family conflict. So this is true in both acute care and the primary care setting. Okay. The Patient Self-Determination Act. This is a concept conceptualized after many landmark right-to-die cases, requires institutions to inform patients in writing their rights to accept or refuse care. So this act relies on state laws and related to end-of-life care, and this act was implemented to improve communication and knowledge about problems at the end of life for patients and their families. So any institution that receives Medicare or Medicaid funds, which are government funds, which pretty much includes almost all healthcare institutions in the United States, because of that, due to this act, they are required to inform patients in writing of their right to accept or refuse care. So this was made, or this act was started to increase healthcare provider knowledge and affect current end-of-life problems that commonly occur, especially in tertiary care institutions. Okay. The last slide I think I'll talk about right now is these two definitions right here, veracity and transparency. So veracity is an ethical principle underlying the idea of trust and fiduciary relationship. So fiduciary means like in good faith. So frankly, veracity basically means providing information that facilitates a person's autonomous choice and trust in the provider. So when I think of veracity, I try to just think of a synonym, which is truthfulness or accuracy. So just, um, the ethical principle that the provider is going to be truthful and accurate in the information that is shared with the patients. And okay, so transparency is the judgment required to make decisions about level of information to give to a patient. So how much information do we want to give to a patient? So even though truthfulness has been long regarded as fundamental to the existence of trust, trust is a fundamental principle in the nurse-patient relationship. Um, and getting the advanced practice nurses are not able to gain a certain level of trust with patients if their data gathering activities are likely to be frustrated and the patient isn't comfortable and with the provider and doesn't feel like the provider is being truthful and accurate. But being too honest or giving patients more information than necessary for decision-making purposes can also be frustrating to their needs. So how much information are we going to give? So for example, we may want to tell somebody about a disease and a disease process and the plan for treatment and the medication and how much pathophysiology do you go into and how many side effects do you talk about for the medication and how transparent are you? And that is a judgment required by you to make a decision about how much information you're going to give to a patient. And it can vary depending on the patient's literacy level, the patient's comorbidities, education level, age, multiple things here. Okay. I'll go ahead and stop here.